Good morning, everyone. This is Patrick Jones coming to you from cloudy Spokane. We will get started here in just a minute or two. We have a very full slate, and we want to give everybody an equal opportunity to tell us what they've been up to. So 2 more minutes and we'll get going. Well, good morning again. This is Patrick Jones at Eastern Washington University, coming to you from cloudy, rainy Spokane. I suspect that that is also a description of what might be happening in your parts of the world. We'll get started here right now because we do have several presentations to make. As before, we would ask you to please give us some feedback at the end of the session. We'll remind you one more time just to do that. So if we could continue here, Stacy. So as you see, it's a pretty full agenda with lots of presentations from around the 9-county area. And it really addresses what has been, I think, I hope you might agree, the heart and soul of what Greater Columbia ACH has been doing the last 3 years, which is practice transformation. And so this is a deep dive, as well as we can do it in the time we have, into what that has meant for all 9 counties, and with many case studies that we hope you will be inspired by and learn from. So why don't we go into the next slide? Is there a volunteer out there who would be ready to read our land acknowledgement? Do we have a hand up? Something we've been doing now for 2 or 3 years, and it's so important that we pause and just acknowledge and make this statement. So would anybody like to just read this brief bit of statement honoring the ancestors that of this land? Everyone is shy this morning.
Hey, Patrick, this is Martin. I can read it.
Okay, Martin, thank you.
Yeah, we should take a moment to acknowledge that the land on which we live, work, and play contain the archaeological resources and tangible evidence of indigenous peoples. It is the historic homelands of the Yakima, Wanapum, Nez Perce, Colville, and Umatilla people who remain committed stewards of this land, cherishing it and protecting it, and instructed by elders through generations. We are honored and grateful to be here today on their traditional lands. We give thanks to the legacy of the original people, their lives, and their descendants.
Thank you, Martin. Thank you so much. All right. Before we start, just wanted to point out that we are convening on the eve of a fairly important day in American culture, politics, and one day that's now pretty universal. In 1970, I don't know if there are enough people of a certain age on the line to remember where you were on April 22nd of 1970. I do. And in fact, I was in one of the Greater Columbia counties at the time. And that was the launch of a day that commemorates something that I think not just Americans, but the entire world is taking a lot more seriously right now, which is our environment. So I don't know what your plans are for tomorrow, but in Spokane, there are many different ways, and over the weekend, many different ways of giving back to the earth. And I hope that you might consider those in your communities. Next slide, please. So as we often like to do before we dive into some case studies, it's important to set the framework, to get the big picture, and to understand why this has happened. And so Sam and Martin are going to lead us off in this introductory part of our session, and then we will follow with our case studies. So Sam, I think you're on first, or Martin, are you leading?
I will be leading.
Okay.
Yep.
Sam is trying to get on, but she's having a hard time to get on this morning.
Yeah.
Okay.
Yeah, I'll it's not a lot of slides, so I can go ahead and do this piece, Patrick.
Okay, the floor is yours, Martin.
All right, thank you. Welcome, everybody. Thank you for being here. The next few slides are just kind of like Patrick said, setting the stage for the presentations that you guys will hear from the several organizations. This slide is a breakdown of partnering providers by type. You guys can see here that we have 3 cohorts currently going through practice transformation. We have primary care providers, hospitals, behavioral health, urgent care, school-based, dental clinic, and long-term care facilities, all within the 9-county region. And all of the sites have done a really wonderful job, and which we will be able to hear from some of the sites here today. But this is just a slide showing the breakdown of all the different provider types that we currently work with. And soon, later on this year, there will be a 4th cohort added onto this chart. It's going to be the Emergency Medical Systems Innovative, EMSI, cohort made up of 10 fire departments within the Greater Columbia region. But that's coming down later down in the years that we'll be starting that cohort. Next slide. And one quick little announcement before I go into this slide. If we can turn off our cameras for those that we are not presenting, that way people in the rural areas, they don't have trouble with their broadband. It makes it a lot easier for them to participate as well. So thank you guys for that. This particular slide here, which kind of cuts off down at the bottom, but this is a breakdown of all the different milestones that each of the sites that are going to practice transformation are working on. Some are, just quarter 1 or quarter 4. Some are every quarter. And you guys can see there the milestones, the categories as to where they pertain. I said, care coordination or access and continuity, 24/7 access, patient-centered interactions, quality improvement. So each of the milestones has its own category of, kind of the work that's behind that specific milestone. In the description, this is just a pretty high-level overview of the description of the milestones. The providers that are on this meeting, looking at the description, they can say, yeah, it's a lot more than just that. We have a proposed budget, empanelment of all patients to a care team or provider. From there, we build off all of the work for practice transformation, going into risk stratification and providing care management, the providing other resources to high-risk individuals, their bi-directional integration of behavioral health, self-management support, medication management and review. So this is just kind of, again, a high-level overview of kind of some of the activities that are part of each of the milestones. Next slide. These are just a couple of snapshots from each of the cohorts that we have in our CA site dashboard. So this dashboard takes data, quarterly data that the sites report on, and puts it into this dashboard, and it trends over time. And then we have cohort 1, cohort 2, and cohort 3. And we can see, follow-up within 72 hours of hospital discharge for cohort 1, cohort 2, and cohort 3, and follow-up within 1 week of ED discharge for cohort 1, cohort 2, and cohort 3. And, it trends it over time. We can see, where the dips are, kind of where COVID started, where we're doing kind of going up, or are we going down? So this is a good indicator for us and our providers as well to see, kind of how they're doing it in their work. So this is just a quick snapshot of kind of some of the activities. This is actually coming out of milestone 6, where they're required to contact individuals after hospital discharge and after ED discharge. And they have been doing a great job with that. Next slide. This slide, Deb Watson from Pullman Regional Hospital, she will be retiring this summer. And we're very happy that we got the opportunity to work with her. We're grateful for all of the things that she has done for practice transformation at Pullman Regional Hospital. She has been the champion there, leading all of the activities and all of the work that has to be done for practice transformation at Pullman Regional Hospital. We're sad to see her, go, because she was just a great champion for practice transformation, and we will certainly miss her in the work. She's part of the practice transformation work group as well. So happy retirement, Deb. We hope that you enjoy it, and that you have a lot of fun. Next slide. Next, we have Somerset Counseling by Jamie Carson. She will be presenting on the activities that have been done in regards to practice transformation within Somerset Counseling. Go ahead, Jamie.
Thank you, Martine. So I don't want to take up too much time because I know we have multiple speakers, but I just wanted to hit on a few things. I wanted to start with some positives, some of our biggest successes with practice transformation. One of the things that have been most helpful for us was, I think, just having the practice transformation team help us pull some of the information and make it more obviously reportable, because look, we're counselors. I'm a counselor by trade, and we just don't think data wise. And so a lot of it was when we would meet with Sam and Martine, we'd be like, hey, we already get that information. We get it in our full assessment, or we get it during our individual sessions. And so they would say, okay, but how can we make that reportable? And so when we were putting our information together, just being able to create some new screenings within our EMR and having that added into our system so that we can make some of this information reportable. And so that's been a really big success for us. We've been able to easily implement the PHQ-9 and the GAD-7. And also we implemented our own self-created social determinants of health screenings for food insecurity and housing insecurity. And so that's been really great. And then having the funding available to switch to a more, I would say, thorough EMR. We switched from Keynotes, which we loved clinically, but it wasn't meeting our needs for the billing. And so we are really happy with our new EMR. But I would say our biggest success within the practice transformation has been our partnerships. I myself as a clinician and as a executive director tend to do a lot of like community outreach, community involvement. We like to bring our partnerships in to build partnerships, like not just over the phone or referrals, but have them come into our staff meetings, and like have really heavy care coordination and a lot of like recovery oriented system of care type models. And so being able to have like an actual firm partnership with Catholic Charities and New Start as part of practice transformation has been really successful for us. We're patient driven, so if our patients want to go somewhere else for MAT services or mental health, that's great, we do that too. But to have like an internal referral system and have like an actual mental health provider on site and do offsite services and things like that has been like a really great experience, something that we've not had before. Some of the barriers we've had, like we'll start internally. And I think all of you will kind of know how that feels. Like I had the buy-in as the director, my admin had the buy-in. We're like, yeah, we'll do this. But then being able to tell our counselors, hey, by the way, we're going to have some additional screening tools of like basically questions you already asked at the assessment, and having them kind of almost have a little bit of repetition where it's like, these are things that you already talk about clinically, but now you're going to have a little bit of extra work. That was kind of a barrier because our clinicians already feel, obviously, you guys know, where they're already kind of buried in paperwork. And so having to kind of get that buy-in from my clinical staff of now you have some additional screening tools that you have to do at different stages of the patient's care, because we have to now have this like a reportable, like, I don't know how to explain it, but like because we wanted the data, right? So we wanted at different intervals of the patient's care. So at first the counselors had a little bit of revolt about that. But the nice part is that barrier ended up becoming a buy-in from the clinical staff, because they were able to pull the data themselves and show the patient that their scores were going down throughout their treatment experience. And that was really powerful for the patients too, to say, you started out really high risk at the beginning, and look at where you are now as you're transitioning to weekly aftercare and as you're transitioning out of treatment. And so I think we've pretty much had some significant buy-in from the clinical staff, but I think they'll always be a little bit salty that we've added all these additional screenings of stuff that we technically gather with our full assessment. I would say our biggest barrier with practice transformation has always been developing an official partnership with primary care. That's been our, as far as like our agency's practice transformation goals, with my navigator, Martine. It's been our, that's like been my little sticking point of my type A. That's been my goal that I've not been able to check off since the very beginning. We did have a pretty successful conversation with one practice, and the actual physicians and their team were really open. We had a great meeting about it. We had some additional follow-up emails about it and a couple phone calls, and they seemed really on board. They seemed open. They had wonderful questions. But then we got caught up in the bureaucracy of what an actual partnership would look like. And the higher up administration put a kibosh to that and would not allow us to have an actual partnership. So we're back to square one. And so we haven't been able to make any sort of partnership happen with primary care this entire time that we've been part of the cohort. And that's been pretty frustrating. So as far as like where we hope to be in the next year, I haven't really thought too far ahead because I've just been kind of a dog on the bone wanting to make something happen with primary care. So we've got a couple more primary care partners that we're hoping to set up some meetings with and try to make something happen there. So I'm hoping that that goal will finally come off of our goal sheet. But I honestly, we're getting pretty frustrated with the lack of movement there. And as far as what can the HCA and the MCOs and the other entities do to help with practice transformation, I feel like they've been pretty helpful so far, as far as like keeping the funding going and having, you know, maybe more trainings. So far, a lot of the trainings I feel like have been pretty more like refreshers. I don't feel like there's been a ton of like brand new information. There's been a lot of trainings that have been more physician oriented. I would like to see some more maybe mental health SUD oriented, but it would be nice to have something a little bit meatier, I guess, instead of something that's more kind of a refresher. But I think we all kind of got hit with obviously the COVID, and that really just kind of threw everything by the wayside. And so I think we've all done the best we can with that. And so just overcoming obviously the last couple of years of COVID, I think we've all done a really great job with that. And I think just resetting, I think will just be really helpful. So did I miss anything, Martine? I think we hit all the things we talked about, but feel free to tell me if I missed something.
No, you did a great job, Jamie.
And I love that I have Martine back. Can I just say that? We bounced around. I had Martine, and it was his first week, literally his first week with UC-ACH. And when he started as my navigator, and then we moved around, I bounced around. I had like 3 navigators, and now I have Martine back. So I feel like it's like total circle.
Right, full circle.
Full circle.
And Jamie always has ice cream in her office too.
I do. I have snacks. I'm the queen of snacks, y'all.
So we've got a couple of minutes. Both Martine and Jamie have been pretty quick in going through their presentation. So
well, I know there's a lot of people, so I didn't want to take up too much time.
That's okay. Are there questions of Jamie and Somerset in general?
Feel free, hit me with it. Come on, Mark. I know you've got something. Mark Lowe's, I know he's on here today.
Well, okay, Jamie, as a chair, I'll pose a question. Maybe people put their thinking caps on here. So tell us a little bit more about the size of your operation. Would you see yourself as a small clinic? And if so, or a medium-sized clinic, if so, has that played a role in your ability to forge partnerships?
I would say we're a medium clinic. I mean, we're a privately owned agency, and so we have 11 clinicians, which is actually pretty good right now. And so, but I would say we're fairly medium. We have we do have a separate adolescent program. So we don't mix adolescents and adults, and we do quite a few offsite services. We have an office over at the Juvenile Justice Center. that we've had for years and years. And I feel like we're always growing. We did expand. So we had, and that was another big part of our practice transformation. We expanded from the suite 6 into suite 5 as well. And so we've grown every year. Somerset's been in the Tri-Cities for over 20 years now. And it started in a teeny tiny office with like 2 counselors over behind on Simon's. And so behind the Dairy Queen. And so we just kind of grow every year. And so, but I mean, we are a privately owned agency versus like a larger network. And so I think that definitely plays a role. But yeah, in our adolescent program, I think is kind of one of the feathers in our cap. We really are proud of that and having it, separate from our adult program. And we're very proud of what we do with our kiddos.
Okay. Other questions?
Oh, in our Spanish program, we have Spanish ADIS, and we have Spanish speaking staff, and we're really trying to grow our Spanish because that's an underserved population.
Very good. So questions of Somerset or Jamie about their experience, their successes.
Jamie, this is Diane. I do have a question. So how do you guys, I know right now that, there's a big push to a lot of people needing services for substance use disorder. How do you guys address do you guys have a long wait time, or how do you guys address that issue?
We don't have a wait time really. I mean, because like I said, we have 11 clinicians. I'm a clinician, so I fill in the gap as well. And so does my clinical supervisor. Both my clinical supervisor and I do not carry a caseload. So as far as like assessments and intakes, we're able to get those in pretty quickly. Like we have openings next week. And so
Awesome.
we don't really, and we do walk-ins. So Monday, Tuesday, Thursday. So and all of our counselors do assessments. So yeah, we haven't really had an issue with wait times.
Okay, one more question. So what can Greater Columbia do better to help you succeed as an organization?
I mean, I think you guys have done really well so far. Everything we've needed assistance with, we've really gotten. I think as far as like meeting our goals, like I said, the only part of our goals for like bidirectional care, like I said, that we haven't had much inroads with is primary care. But and it's not for lack of trying. Like Sam, Martine, like we've tried. So I don't know that you guys haven't done anything. You know what I mean? Like you guys have met our needs.
Awesome. I just wanted to check and see if there's anything that we could, do better. So I'm glad that you're happy. That's important to us.
And I'm not exactly quiet, Diane.
I know. We love you, Jamie.
All right. More questions of Somerset or Jamie of the experience in the Tri-Cities. Did Jamie, you thought that Kirk has a question?
No, I was saying if Mark Lowe's was on, I was surprised Mark hasn't hit me with something.
Okay. All right.
Yeah, I guess.
Come on, Mark.
The thing with the primary care, are the admins afraid of the CFR 42 and doing a QSOA? Is that the problem with the confidentiality?
I don't know, because I don't know. I don't know what they're afraid of, because it's not like it's not doable.
Right. That's interesting. I wouldn't have guessed that until I heard it. So that surprises me. But maybe it's just they're so busy they don't need the business. I don't know.
I don't know. The one office that we were super close to having a partnership with, their administrator they were part of a network. And up until recently, that particular office was like, hey, we've always been able to have contractors, subcontractors do whatever we want. But that network had pulled back and said that as of right now, we're not doing that anymore. You have to go through corporate.
Well, we will definitely be, trying to help you facilitate that. I mean, I know that that's been a goal for Greater Columbia for our partners. So we'll definitely, I'm sure Martine and Sam can, hopefully we'll be able to help you reach that goal.
Which was frustrating because the doctors and the nurse practitioners and all of them, they're like, we didn't even know you guys were there. Like we have patients that have SUD problems and mental health problems, and we don't, they're like, this is wonderful. We need support and we need referral options. And we even had referral options to other SUD programs. Like it's not just us. Like we were like, we want your patients and services anywhere. And so they needed help for their patients. And so it was very frustrating that we couldn't get something going.
All right, well, something that we can look into, right? Greater Columbia staff, Martine, Sam, Diane?
Yeah, definitely. Jamie and I have been working passionately on this as well as Martine. And so we're definitely looking at other avenues of trying to really be able to get this SUD connected with some primary care, right, Jamie?
Yeah, especially now that we got the band back together.
Wonderful.
Yeah, we're always looking for those, sort of natural partnerships, Patrick, that we think, hey, that would be a good relationship between you two, and, make that facilitation and set up meetings for them. It's just unfortunate that, the, higher up leadership doesn't see the benefit, which is, it's a negative impact, on the community, because the more people that are entering services that need it, the better. So just another roadblock, but we'll definitely keep our eyes and our ears out to see who we can connect you guys with, Jamie.
All right. One last question of Jamie before we move on to Tri-State.
Man, you guys let me off easy. I'm here for it.
The note in the chat here, Jamie, from Kendra. You want to be part of that with Somerset when it happens? Yes,
because Kendra is my partner over at Catholic Charities.
All right. Okay. Well, thank you so much, Jamie, for that candid appraisal of how things have gone. And we hope you'll be able to stay with us throughout the rest of the meeting. And now we're going to shove off a little bit to the east over to Clarkston and hear from Tri-State. And we have on our agenda 3 presenters. I don't know which of you 3 is going to start.
So I'll start, and actually we have 4 presenters. So my name is Jolene Carper, and representing Tri-State Memorial Hospital. We are a critical access hospital here in Clarkston, Washington. And we have been blessed to be part of the GCACH Practice Transformation Cohort 3. And Martine, if you can go to the next slide. We have 3 sites that are participating, and the 3 directors for those different areas are actually going to speak, but I will introduce them. Tri-State Family Practice here in Clarkston will be represented and spoken about by Kelly Pease. Our behavioral health clinic, Joshua Gartrell, will speak about his endeavors, and then the work that's been done in the ER and inpatient units will be addressed by Carrie Lopez. So we just want to really thank GCACH for the opportunity, obviously for the funds. And I think as these 3 presenters talk, you will see that we've put the funds to good use and really have been able to do some things that we wouldn't necessarily have been able to do, without the cooperation, the funds, and really sometimes the ideas. So I think from here, we'll go to the next slide, and Kelly Pease from Clarkson Family Practice will take it over.
Okay, good morning. I am going to have somebody else move the slides for me, please. I don't know. Oh, thank you. Magic. Tri-State has 3 primary care clinics. The clinic that I manage here in Clarkson, and we have 2 more in Idaho. So we have quite a good group that will focus on the Clarkston clinic because that's where we're participating with the GCACH. So as you can see on our slides, we have quite a volume of patients, and barriers like everybody else had to go through was the pandemic, trying to figure out how to still take care of and serve our patients when we might or might not be able to get them in the clinic. So we utilized virtual visits, and our providers got really good at them, and we tried a couple of different platforms, and everybody seems to have their favorite platform. Another barrier that we have had is just buy-in and understanding. Providers understand the need for the screenings and how that affects patients' long-term health, but patients don't always understand why they need to come in when they may not be sick, or why they need to have screenings for disease states that they don't have. And then, complexity of health. Some patients are pretty healthy and some patients are not. And trying to get patients to understand that there is a time and a place to be at the minor care, or a time and a place to be in the emergency department, but definitely a time to come to your primary care provider for that continuation of care. So we've really been working to overcome those barriers. We have been working to educate our patients. We've given a lot of feedback to our providers and our support staff, and even our support staff talk to them about the ways that when they're scheduling a patient, they can help support that need for that wellness visit, or that diabetes check, or that cancer screening. The funds from the GCACH have been very helpful in forwarding a lot of our projects. We were able to hire a second care coordinator to help part-time between our clinic and part-time between the diabetic educator. We've developed a lot of handouts and educational tools. We've worked with some of our other partners. Our Cologuard rep has gotten us some really great information that doesn't just promote Cologuard, it promotes that the colon cancer screening that a patient will do is the best one for them to do. We've come up with handouts for the patients to give them actual examples of things that you come to your primary care provider for, things that you go to the minor care for, and things that you go to the emergency department for. It's just been really nice to have somebody kind of helping to guide us as we've been walking along this path. And Martin and his team have definitely provided us with a lot of information, a lot of support. And then, in our meetings, we'll bring up questions that make us maybe think of things that we're already aware of, we're already doing, but to look at them in a different way. So having some additional resources has been really, really helpful. We're working really hard to reduce our emergency room department visits. Over the course of time, we've reduced those visits by about 50%. And it's been multifaceted on how we've worked on this. We get a report every day from the hospital that tells us which of our patients have been in the emergency department and which of our patients have actually been inpatient and discharged. And so we have staff members that work that list every day. They get a hold of that patient, they make sure that they're doing okay. They offer them a follow-up visit, to make sure that they're tucked in and that everything's being taken care of well. We've improved our diabetic patient control. That we have a list of our patients who are diabetic, and our chronic care manager goes through that list and looks to see who's been referred to maybe dietary counseling, or maybe referred to have a diabetic counseling appointment, or even nutritional services. And then they look through the charts to see whether the patient took advantage of that really great benefit. And if they didn't, then they contact that patient and they have that conversation again about how this can help and maybe what was the barrier of getting them to those referred appointments. We have a really nice story that I got from one of the diabetic educators. She was working with a patient whose A1C kind of kept going up and going up and going up. And finally, the patient got comfortable enough with her to say that his living situation was horrible. Sounds like he was renting a room with multiple people. He didn't have a safe place to keep his insulin because it was a shared refrigerator. He didn't have maybe the best place to keep groceries and healthy groceries, living on a really tight budget. And Liz was able to refer him out to a local resource that helped him find housing. And the patient has reported back to her that now that he has his own place, he feels comfortable putting his groceries in the refrigerator and he's tracking his insulin and using it better. His A1Cs are starting to improve. So a lot of that one-on-one that maybe can't happen when the patient is with the provider is happening when the patient is talking to our external staff. Our behavioral health department was able to add on another team member, a nurse practitioner. That's been fantastic for primary care because it gives us an additional resource to send our patients to. It helps our patients get seen sooner. We've had improvement in our initiatives like our mammograms and our eye exams and our colon cancer screenings. And again, some of that goes back to patient education. Some of that goes back to those one-on-one conversations that people are just more comfortable having. The more we have them, the more natural they feel and the better we get at it. We've even had a lot more buy-in and understanding from the patients. We've had some really good success stories as well. So medication assistance, again, another conversation with our chronic care managers. And an example is a patient who, urology patient, provider had recommended a specific medication and patient just couldn't get it covered through insurance. They got a denial on it. And so our care coordinators tracked the length of time that denial is good. They dug through the chart. They reached out to insurance. They did all the paperwork and things that they needed to do to get it covered and to get that patient their, oh gosh, I can't think of the name of it, that 24-hour blood sugar glucose monitor. So they've also worked to get patients their Myrbetriq or their Gemtesa, which are two urology meds that are a little more expensive, and it's not something that generally gets approved right off the bat. Our diabetic education and nutritional counseling, like I said, reviewing those charts and having those conversations with the patients. Some of the additional resources that we've taken advantage of are those fuel cards. We've referred patients out to local services such as the special mobility services for rides to their specialty appointments. We don't consider ourselves super rural, but we are kind of rural. We're a couple hours from the bigger cities, and it's not always financially possible for patients to do that 2-hour drive to see a cardiologist or to see another specialist that takes Medicaid and we'll see those patients. And so if we can't get them a ride through this local source, then we've provided them with fuel cards so that they can afford the fuel to go, or maybe so the person who is going to be their ride can afford the fuel to take them to those appointments. Over the next, can we advance the slides forward a little bit, please? Over the next 12 to 18 months, one more. So over the next 12 to 18 months, we're going to continue our current processes because they're working. We're going to continue to reach out to our patients, and we're going to continue to try and identify some of their very serious needs that a lot of us take we don't even think about it. It's not needs we have, so maybe we don't think about it. We're going to be updating our retinal imaging technology. We're using a system called RetinaView, and we're going to be putting in a newer, more advanced system that's easier for the staff to use. It's quicker to get those results for the patient. And there's now a pediatric option. It's not necessarily going to check for the diabetic retinopathy, but it's going to check for signs of early eye problems in infants and toddlers and younger kiddos, which I think is going to be fantastic. Get them help with their eye care a little quicker. We're looking at purchasing blood pressure monitors for our patients who are struggling and don't have the funds to track their blood pressure at home. Everybody knows you can go to the pharmacy and use that one that everybody plays with and little kids play with, but that's not handy. And patients can't always get into the pharmacy twice a day. So by providing these blood pressure cuffs to them at home, they can track their readings, they can report back in. We can get a closer eye on managing their hypertensive. And this is, again, a detail that we, day to day, those of us who don't have a struggle or an issue or any kind of roadblock. When our care coordinators started researching these, they even looked for ones that can use an internal battery and can be recharged, thinking about the fact that not everybody's going to be able to afford batteries for their blood pressure cuff. That was just eye-opening to me, and it just really helped to confirm for me how hard everybody is working on behalf of our patients. We're going to continue to do patient education materials. We're sending nursing staff to special CMEs where they're going to get more information that's going to help them care for our patients. We're going to continue provider staff and patient education. And a couple of things that we feel like maybe the HCA can do to continue to support us is to continue to reach out to the Medicaid organizations, try and urge them to help us with roster accuracy. When we go through our rosters, sometimes we find patients who are assigned to us that don't live in our area, and we don't see them, or patients who have transferred to another provider that's outside of our organization. And so we do what we can to try and clean up those lists. We'd love to see more work and more focus towards those ED utilizations and maybe patients who no-show or don't have follow-through with their appointment. Because the more people we have coaching those patients and urging those patients and educating those patients, the more successful that patient is going to be with their overall healthcare. So again, just really grateful and really thankful that we have the opportunity to work with the GCACH.
Right, thank you, Kelly. And we've got a couple other presenters from Tri-State.
I believe behavioral health is next. Yes.
Yeah, and just for you, Joshua, and you've got no more than the two of you. We've got no more than 10 minutes between the two of you.
Sounds good. I'll be quick. Again, thanks for the team for all the partnership. Couple of successes. Kelly briefly mentioned, but I would be neglect to say that without GCACH, we wouldn't have been so proactive and so confident and assured in adding that third provider. We added a new nurse practitioner this last year, and it's been a phenomenal asset to our organization and to our community. So very appreciative of that as well. The other thing, a more recent one, is we implemented a transcranial magnetic stimulation TMS therapy that's embedded into our behavioral health clinic. And this targets folks that are resistant to medication treatment for major depression. And this has been a phenomenal asset and new service that we're providing our patients beyond just medication assisted therapy and treatment. So we're very excited about that. We've also really increased our coordination of care culture for all of our staff. Folks that have a long behavioral health history that's kind of embedded into our training and our background, but for staff that are either new to behavioral health clinic or different roles, whether it be clerical, clinical, support staff. We're trying to increase that entire culture of coordinating care, and we've really done a good job of increasing that culture to all staff, regardless of their role in the clinic, to have them see as contributing towards that culture of coordinating care for our patients and for their quality care. Couple barriers, we implemented this during the pandemic, and I think we all have felt that. And this is nothing unique to us, but as we did see nationally and also locally, this did increase patient demand for behavioral health services in the midst of pandemic. As we're trying to create and grow this as well, the demand, it was difficult to keep up with. And so the challenge of staffing, hiring, recruiting, and retention in the midst of a pandemic was extremely difficult and put a lot of pressure on existing staff and those coming in trying to be trained to be effective. How did we overcome these barriers? We used creative ways in using our staffing floats and did some, cross training, coverage to ensure patient care was not delayed. And so we really tried to, before the pandemic, everybody had your niche defined job duty and role maybe on your checklist, but during a pandemic, it's all hands on deck, and there's a lot of cross training and cross coverage of duties, and really just supporting the team on behalf of making sure that we were being effective in patient care and being responsive to our patients. Next slide. Where do we see ourselves in 12 to 18 months? Continuing to promote the culture of improving the quality of healthcare delivery to an often marginalized community of patients, and possibly add a psychologist for evaluations and therapy at our clinic as well. We continually are getting requests for psychological evals and recommendations from a psychologist, and we currently don't have one in our clinic. And I think that that's a need that our community has here in the Valley, and I think that we would be wise in trying to meet that need. I think what we need further is just continue resources and targeting staffing, infrastructure development that directly benefits patient quality care. Making sure that with limited resources, time, and again, the demand outpacing the resources we have, making sure that the resources that we do have, any additional resources coming in, directly benefit the patient quality care. I mean, that's ultimately the goal and why we do what we do. Brief success story. I was hoping to get a little bit of a narrative written from a patient, but just some oral feedback from the patient was, we had a patient receive the TMS treatment, and someone who had suffered with major depression for decades and was resistant to medication and just lost that joy of life, the joy of the simple things, and just could not see any hope or end to the depression. And to hear from a patient that their life is now again what they are experiencing mentally, emotionally, socially, in their daily life that they haven't felt in decades as a result of this treatment. Those are the stories that just keep you going, knowing that why we do what we do is when a life is changed and how it affects them, their marriage, their relationships with their family, at work, and just how their life can be changed through treatment and the services that we provide. It just makes all the difference in the world.
That's a good way to end, Joshua. Thank you so much. And maybe we'll have time for questions, not now, but at the end of the session. So to wrap up, is it Carrie? From anybody else from Tri-State?
Yeah, I think Carrie is our next presenter.
Okay.
Can you guys hear me?
We can hear you.
Okay, perfect. Yes, so my name's Carrie Lopez. I'm the Director of Care Transitions and Patient Flow. I oversee our House Supervisor, Case Management, Discharge Planning, and Utilization Review groups here in the hospital. As Jolene mentioned earlier, we are a 25-bed critical access facility, but we do have a, we're in a fairly populated area. And do have a wide variety of patients that come see us. Our main focus with the grant was towards the emergency department. So as you can see, our goals were to reduce emergency department readmissions, reduce inpatient readmissions, increase access to behavioral health services, increase access to primary care providers for patients coming into the emergency department, improve care transitions and treatment strategies for individuals with substance use disorder and psychiatric diagnoses, connect vulnerable individuals with services that promote safety in the home, and then identify a funding source to pay for urgent low-cost patient needs, such as, an antibiotic maybe for somebody who is homeless and not insured. So what we did was take a look at our needs and the actions, what we were able to accomplish. The primary one, and I think the one that's made the most impact, was that we hired a second ED-based RN case manager. So I think we're quite unique in that we now have an RN ED case manager 7 days per week, beginning at 10 a.m. Through 8:30 p.m. And they have been really key in doing a lot of things to help patients and families that are coming through our emergency department and streamlining the flow through the hospital. We also were able to contract with Array Behavioral Health for telepsychiatry services. We created a process where we streamlined referrals for new primary care providers and to our behavioral health clinic. We initiated SBIRT screenings in the emergency department for at-risk patients. We were using Collective Medical's ED, the emergency department information exchange, previously, but we've now have an interface in place to make it easier to provide care guidelines and to receive information about patients. And we've also just recently been able to use their value-based care services, their platform for that. We've provided staff training on SBIRT, motivational interviewing, telemedicine, and mental health first aid. And we've established a process to provide patients with the funds. Like I said, medications, maybe somebody who doesn't have the funds to pay for their antibiotics or who doesn't have money for transportation to a medical appointment, so on and so forth. We've bought, supplied catheters for patients. So that's been really helpful. Go ahead, next slide. So our biggest success, as I mentioned, was the ED-based case manager. So that role, they are contacting patients who leave the hospital against medical advice to follow up on their care and safety, make sure that they're safe. A lot of reasons why people might leave against medical advice. We've had patients who leave because they have pets at home that they want to take care of, or because they have an addiction issue and they just can't manage that in the hospital setting. But that doesn't mean that they don't deserve medical care. So we want to make sure we're contacting them and that they're getting followed up with. We'll initiate referrals for ED patients who need the primary care provider. And we've collaborated with Jolene's staff in getting those referrals streamlined and a lot of patients set up with new providers. And the same with the behavioral health services. I've talked about the funds before. The ED case managers really facilitate that. The SBIRT screenings, collaborating with DCRs for placement of psychiatric patients, and facilitating those telepsych consults for the ED patients. That's been supremely helpful, especially with medication management. As through the pandemic, we were able to it was really challenging to get patients placed in psychiatric facilities. And so if we had a mechanism by which we could start medically managing them through medication adjustments or initiating new medications that helped them while they were with us in RED, so they weren't just languishing and regressing while we were waiting for placement. And on occasion, at times they actually were able to improve such that they were able to be discharged from our emergency department, not even require transfer to an inpatient facility. They've also been able to place patients directly from the emergency department to skilled nursing facilities, long-term care facilities, and then make referrals to home health agencies, provide referrals for DME, that sort of assistance. I think I am running out of time here, but anyway, so you can see everything that they've done. They've just been supremely helpful. Biggest barrier has been technology, of course. Anything with getting interfaces where IT and that sort of stuff, but just getting some reports, assessments, referrals, multiple hands in that pot, but we've overcome that. Just communication, keeping at it, making sure everybody is communicating with each other effectively, testing processes, and using our IT resources and consulting them. So I think the funds that we've received through the grant have been great, have been made a tremendous amount of impact on our patients. All of our numbers have greatly improved readmission rates and all that stuff. So I can't speak highly enough about the program and the support that we've received during this project.
Thank you. Is that it, Carrie?
That is it.
Okay, well, thank you so much to everybody from Tri-State. We're going to hold off on the questions now. We're running a bit behind, and we'll try to pick it up at the end of the session. So those of you, that was a lot of information from Clarkston, and we thought it'd be good to have a critical access hospital report out about its experience with practice transformation. So hopefully we can come back to that setting at the end, but we do want to catch up and allow Sun M Ranch to give its presentation before we take a break. So Mark, the floor is yours.
Morning, everybody. Hope everyone is well. So if you don't know who we are, Sundown M Ranch is a private nonprofit that's been providing substance use disorder services for well over 50 years. We were established in 1968. We're CARF accredited for 10 different programs, all SUD related. So we treat both adults and youth, inpatient, outpatient, assessment, referral, and withdrawal management. Go ahead to the next slide. So our focus is really integrating SUD with primary care. To do that, we really had to develop an outcome system for the transformation project. So we've been doing outcomes for a long time. Being accredited, you have to do outcomes, but there were some specific goals within the TP project that we needed to build. And then really tracking that performance through a team and lots of collaboration and teamwork. Next slide. So some of the obstacles were, being an old organization, there's lots of history, lots of culture. Our medical director was with us for over 40 years. So while that brings a lot of consistency, it also brings some rigidity and some difficult, it's sometimes difficult to make changes. And all of those processes on the medical side, he's a psychiatrist, so all of those processes were fully paper. So there was a kind of segregation between our EHR for the clinical side and paper for the medical side. So we had to kind of work those all out. And generally, organizations of this size are fairly siloed. So you kind of have the admin, the clinical, the medical, the med room. And then we also do mental health services through an offsite psych ARNP. So trying to get all of those working together to meet some of the measurements in the transformation project was a challenge. And then, just finding a medical director. So we looked for 5 years to find a full-time medical director, and luckily found one right before we started our transformation project. And then finding some support staff for the MD was also challenging. Labor cost, obviously, billing med services. So historically in our field, we got a daily flat rate on all the inpatient services, and there was really no opportunity to bill for any med services. So most providers didn't do a lot of it because you couldn't get paid for it. And then once we kind of implemented it, an obstacle we found later was managing patient expectations of what we could actually do medically here on site. Next slide. No, well, solving these obstacles. So we hired some medical staff and then built teams. And that's probably the thing I'm most proud of, is the way we're able to kind of overcome the silos and develop these collaborative teams to work on the medical policies and procedure development as we transition from a medical director who was here once a week to a full-time, fully integrated program. Yeah, so that part was really fun. So we implemented daily morning meetings. So the clinical med team and admin are all in on these meetings, and there's a variety of topics, but a lot of it's real patient centered. So this is really discussing the day and who's going to be seen and what needs the patients have, and then what needs each team has. And then that developed into a monthly kind of QI performance improvement team that meets and has some measurements that we're reviewing and also discussing just day-to-day functions. And some nice reporting comes out of that. We developed some new metrics in our outcome system, ongoing review of data, which allows for rapid responses. So if we see a trend, we're able to respond rather rapidly because we have dashboards that have data available. COVID actually really prompted a lot of telehealth. So we're doing a lot more telehealth than we had before, which has been useful in not just in outpatient, but in the inpatient side as well. And then moving a bunch of processes from paper into the electronic health record. And flexibility and adaptability was crucial during this process. I think the first few times we did reporting, it could take me a couple of days to actually put that report together because of just the way the data was. And so each quarter we improved and we're able to kind of develop and improve the system to collect better data in a more effective and efficient way. And anymore now it takes me 5 minutes to pull all that data together, and then it's just basically getting on the portal and uploading the data. It's so much more effective. Next slide. So success is obviously teamwork, collaboration is a big success. We've seen increases in overall outcomes with integration, huge decrease in ER usage. So, even though we have a doctor here, the patients sometimes are not interested in seeing our doctor and demand to go to the ER, but we've been able to reduce that a lot. It's really one of the greatest benefits or successes has been the increase in access. So having full integration with medical has allowed us to take more complicated cases, so we get 1,000 calls a week roughly. And, some calls, it used to be we might send them to a higher level of care for a few days because we were a little concerned about managing them or their risk or their medical problems here. Which is, obviously with the substance use disorder population, any stops that they got to make is, going to present some challenges for them. So I think this has allowed us to access to people that were more complicated medically, which is obviously a big win for us and the consumers. Historically, all lab work, TB tests, all that stuff was done off site. So we'd have to load patients into a van, transport them into town, and another provider that we had collaborated with would perform those services. And virtually all of that is being done on site now, which is a less disruptive to the patient, to the consumer, and just a huge benefit. Medication assisted treatment, we did 0% before transformation project, and now over 50% of every patients we serve are receiving some form of medication assisted treatment. both for opioid use disorders and for alcohol use disorders. So that's been a huge change philosophically for us, and I think just a huge benefit for the people we serve. And we serve a lot of people. I mean, even with a reduced census due to COVID and the social distancing, during the transformation project, we've served well over 6,000 patients for substance use disorders in this time. One of the things that's kind of interesting is we don't do mental health services here. We're not a licensed mental health provider. We do a lot of mental health kind of counseling, but it's not something that I'm licensed or billed for. But we see an average in PHQ-9 and GAD-7 drop 60% from admission to discharge. And, that's fairly short term. That admission survey is done when they check in, and the discharge one's done 2.5 weeks into treatment. So seeing a reduction of 60% really shows that whatever holistic, balanced, patient-centered treatment that we're doing for SUD is really having a positive effect on depression and anxiety scores. And then telehealth and telemedicine have been two things I've been really happy about. It's really increased access for outpatient, for our care coordinators who are setting up aftercare for folks. Now, they can be from anywhere in the state, and they can still do outpatient with us if they choose to, which is just another access point for them. So that's been a real benefit. And say, doc is home or the ARNP is not available to come out and site, we can still address our integrated medical needs for our inpatient patients through telehealth or telemedicine visits, and not have to take them into town. So that's been a big win. And I could clearly talk a lot about patient successes, and I think some of these numbers really show those successes. But the one I want to talk about the most is Emily, who's a staff member here, who's our main medical assistant, who was a receptionist working here in the admin building, who's was a certified medical assistant, but was not using her MA at the time. She was working as a receptionist, and this project actually opened up a door for her to put her credential to use. And she's really the person that's the hub of everything between me and admin, clinical and medical, and just kind of making it all work for the organization and the persons we serve. So it's been really a pleasure to watch the growth in her and how much she contributes to our patient-centered philosophy here. Next slide. So we're in the process of an EHR upgrade. It's the same EHR we're using, but it's a new version of it that's a lot more modern, a lot more handheld friendly. So this is going to allow us to kind of totally eliminate paper. There's still like a handful of things out there that I want to get rid of. It also has a patient portal and more digital capabilities for on the medical side. So that is ongoing, a big project, but going to be very rewarding when it's done. Billing for medical services. So this has been something I've been working on for a couple of years. We've been working on for a while, and we finally got med services in our contract language, and now it's just kind of figuring out how to get that all working. And I think that'll lead to us hiring more medical staff. We did hire another MA, so we got 2 of them supporting our medical director now. And then moving forward, I see more collaboration with community partners, especially through telemedicine. I mean, I envision a day where, we're partners with primary care offices that aren't big enough or that are very rural, that don't have SUD specialists or behavioral health specialists on site and have limited access to them, to where we could use telehealth as an opportunity to provide, BH or SUD services for those providers that are struggling finding those. So I think that's an opportunity for a lot of us moving forward. And I think that's it.
All right. Thank you so much, Mark. That was a perspective from the view of a substance abuse disorder provider. We're trying to sort of run the gamut here of practice transformation. Before we move to a break, are there any quick questions of Sundown, M Ranch, and Mark. If anybody's shy, you can type it in the chat, or you can raise your hand or just speak up.
And if I could just add that, you know, this project, working with the GCACH has been a real pleasure. I mean, I've developed some friendships with the folks there. It's been a great collaboration. Really appreciate them and the teamwork and the support they provide. But this project really forced us to design and implement things that we've been talking about for decades, you know, that were just kind of always in the strategic plan, but kind of on the background, and, you know, like, oh, this is going to be so much work. And then it was like, here's an opportunity to do something and be part of something. And it really forced us and me to drive it forward. And so I'm very appreciative of the ACH and our peeps there, and just nothing but good things to say about this collaboration.
Okay, that's great to hear, and hope that I'm sure Martine and Sam and company would like to carry that on, Mark. All right, well, let's take a break. It's going to be a short one, folks. We'll be back at really 10:20. I've got 10:16 on my computer clock. So thank you all for your attention, but don't leave. We're going to have some great presentations after the break. All right, everybody. I hope you have taken your break and done whatever duties were required of that. You've tanked up with coffee. You've got a coffee cup nearby. And we are about to launch into the second round of our case studies. And we are about to hear about practice transformation in oral health. And the agenda shows one presenter, but it looks like we've got three. So Cassie, since you're listed first, is that you, or is there somebody else who is going to step forward for Chaz?
It will be Shay. Patrick.
It's going to be Shay, all right.
Yeah. They abandoned me today, so I'm flying solo. Bear with me, everyone. Good morning. So my name is Shay. I am the quality improvement coach at Chaz Health. I work at both our medical and dental clinics. Today, you're obviously going to be hearing about the work that we've been doing at our dental clinic. Next slide, please. So I always like to start with our successes. First and foremost, we are the first and only dental clinic to participate in practice transformation. And we've been able to expand resources to a wider patient base by thinking outside the box on what questionnaires a standalone dental clinic can administer. So for example, we've been screening our patients with the PHQ-4s. We started with the PHQ-2s and then transitioned to the PHQ-4s. And then we recently started screening patients with PREPARE, which is the social determinants of health screening. Another success is just continuing to think outside the box and breaking the mold for dental clinics. Some barriers: staff and patient buy-in with non-traditional screening questionnaires for dental-only locations. That was a hard one for our staff to really engage with. And patients as well, they originally found that the questionnaires were kind of intrusive and didn't really see the benefit of having these questionnaires being given to them at a dental clinic. We also have a lack of behavioral health services in the area in general to complete the follow-up portion of these screening questionnaires. So like our PHQ-4s, we're trying to get our patients in with behavioral health services, and the wait time is, several weeks to several months out. Also, we don't have traditional provider patient panels at our dental clinic, and so we've had to kind of work around that as well. How we've overcome our barriers: we like to explain the why. Why we have our mission, why we're doing the work we do is very important to our staff. And we educate our staff and patients on the benefits and importance of the screening tools. We also have a really strong team and develop the different processes and explaining that it's not just a referral. We worked on creating different buy-in and a process to close that loop. Explaining the follow-up piece to staff also helped realize, what happens after the referral is placed, that it's not just entering a referral, it's not just, documentation, just making sure that we are actually caring for our patients. And then providing staff with the vision of a big picture and providing them with the right tools. So we did have several staff members attend mental health first aid training. And recently we had the YWCA come over during site meeting at our Clarkston clinic to kind of go over how to have difficult questions or difficult conversations with our patients, specifically surrounding like domestic violence issues. Next slide, please. So for the next 12 to 18 months, our team is going to continue perfecting the workflows and making the work that we've been doing sustainable outside of the transformation project. We want to continue to think outside the box on what screening tools we can offer at our standalone dental clinic, and possibly spread this work and implement it at other Chaz dental locations, because currently Clarkston is the only clinic that is administering specifically the PREPARE screener. How we can have some support from the HCA and MCOs, possibly by modifying their processes and forms to allow for standalone dental clinics to participate more easily. And then looking to have more dental participants in the future transformation projects so we can see what other clinics are doing and kind of discuss and collaborate on best practices. Next slide. So this one really touches my heart and I get kind of emotional about it. I apologize in advance. But with our Prepare Screener, this is just, it really hits home on our why we do this. So there was a young pregnant woman who was being seen for a dental appointment in Clarkston who had a positive screening for needing housing resources. Our community health worker reached out to the patient and she was able to identify that the patient was living in her car. The ACHW connected the patient with Quality Behavioral Health, where they were able to secure her housing. And the patient was also referred to the Reliance Center to get prenatal care. Since connecting the patient with QBH, she has been able to obtain further assistance. This patient hasn't seen Chas Medical, or has seen Chas Medical, but hasn't been engaged since about August 2020. And if we didn't offer the Prepare Screener at the standalone dental clinic, the barriers that she was facing may have not been ever identified or addressed, and the patient could still be living in her car. Next slide. And that is short but sweet.
That was very well done, Shay. So I've got a couple questions, but let's see if people have questions online or from the floor, so to speak, about the experience in your standalone dental clinic, which is quite unique. Questions of Shay and the Chas experience in Asotin County.
Hey, Patrick, this is Martin.
Right.
I just wanted to add a little more to their presentation. Since they are the only dental clinic going through practice transformation, and they're in the Clarkston area, and we have Tri-State, which you guys heard from already, and then Quality Behavioral Health, which you guys will hear in just a few minutes. All three organizations have a collaborative agreement in place. Where Tri-State Memorial, where if they see a patient and they identify a patient that goes to the hospital for any sort of dental pain or dental issues, then the staff there already know, hey, we have this resource in Chas that we can refer them to. And so any of those patients that go in for any sort of dental issues, they refer them over to Chas, so that Chas can provide those dental services. And then with QBH, they have that partnership, and then they're able to refer to behavioral health as well if that's a need. So it's just a really neat community there, and the work that they're doing, it just really reflects on the work that they presented today.
Okay, thank you, Martin, for giving us a bit more of the framework there.
I just want to say kudos for A, the commitment of your staff, B, one of the things that we've worked to create here, and quite frankly aren't nearly far along as you are, is the idea that there's no wrong door, that when somebody comes through the door, that may be the only opportunity you have to make that first contact. And your case study is awesome. Thank you.
Thank you, guys. I
Dr.
really appreciate that. I know, just in addition, our dental clinic has been really good at also submitting primary care referrals to our medical clinic for patients who don't have a primary care provider as well. So if they have someone come in, that's screen positive on either Prepare or the PHQ-4, and they don't have a PCP, we are able to have those resources and connect them with a primary care provider over here in medical, so we can continue to get them assistance if need be.
Okay, thank you. Any other questions of Chas Dental or in general of Shay? Shay, I just going to pose a quick question, and I wasn't sure from your notes or from your comments whether this had been overcome. You said initially your patients were a little taken aback and maybe found this kind of questioning a bit intrusive. And you say you've done quite a bit of staff training to remedy that, but what about your patients? Are they a little more at ease with that sort of
Yes.
question?
Yeah, they are. So obviously in the beginning, both employees and patients were feeling like this is an intrusive process. It's, how is this beneficial in dental? But once we got our staff trained, they were able to explain the benefit to the patients. And really the conversation opened up is we're not here just for dental care. We are here to care for you as our whole patient. And even though we're not providing medical services, we want to make sure that any issues or barriers you may be experiencing, we can help address them for you.
Mm-hmm.
So patients have been really receptive to it, especially with that conversation opening up.
Okay. So maybe then your patients, like Dr. Martin, feel that they haven't entered a wrong door, but this is a helpful door.
Yeah. Yes, sir.
All right. Any further questions of Shay and the Chaz Clinic in Asotin County?
Yes, Patrick, I do. I wanted to ask if they can talk about when they very first started practice transformation. We have a new cohort that's starting and they have all those questions just like Chaz had at the very beginning. So is there any words of advice for the new cohort that would be starting under the EMS program?
So I am actually a newer QI coach. I started on this project the end of September, so I don't know if I can answer this the best way possible, but really communicating with our staff and creating a collaborative team environment is really how we've been successful. And recognizing that when we try something and it doesn't work, we can kind of reevaluate and change things up just a bit to make it work for our system.
Okay, well, Sam, maybe that's a conversation you can have then with Chaz as we get into cohort 4. All right, let's thank you so much again, Shay, for the presentation, and I think you've stimulated a more discussion. Typically, dental and oral health has not been a part of the mix, and yet you have been. So maybe there will be more. Moving on to a relatively, for our region's definitions, a relatively large primary care clinic. We're going to hear from Palouse Medical. And Teresa, I don't know how you pronounce your last name, Teresa. Is that Kuwait?
That would be Teresa Quate, although I'm blocking her.
Oh, okay.
So I apologize for that. My name is Terry Jane Osborne and I go by TJ. And I'm the executive assistant here at Palouse Medical. And Teresa offered me the opportunity to represent Palouse Medical and kind of give this rundown on what we've been doing the last couple of years. So I apologize. If you wanted Teresa, I'll move over so you can see her more.
She's got a mask on, hard to hear. Go ahead.
Okay. So first of all, I just want to say good morning, Greater Columbia. We're really excited to be able to have this opportunity to let you know what we've been up to the last couple of years. And just listening to everybody's presentations, I am so impressed by all the work that's being done and the lives that are being changed. And I just love that. That's really amazing. I think we need to take a moment and all of us need to know that all of the hard work that we've been doing, it really does pay off and we're making a difference in people's lives. So that's pretty amazing. So if you can scroll to the next slide. Perfect. So I just want to introduce you to what Palouse Medical looks like and where we're at. I know that I've got a couple of friends here. We've got some people that are from Pullman with Pullman Family Medicine on the line, and I think some Pullman Regional Hospital people as well. But we're in the Palouse, and so we're serving a rural population and a transitional community of well over 100,000 lives. That's not that we're necessarily impaneled with all those people. We serve about 10,000 patients, but Whitman County has about 50,000 lives and Latah about 40,000 lives. And then we've got the 2 universities. So we do see a lot of different types of dynamics in our community. So we're always trying to balance that as we're providing care. About us, we are a multi-specialty clinic. We're privately owned. We have 10 primary care providers. And our services span across the fields of internal and family medicine. We do have OB care, family planning, prenatal and delivery, non-invasive cardiology, diabetic education and management, One of the things that we're really going to cover in this presentation is our integrated BHI services, and we have a full-time on-site health psychologist, Leslie Robeson, that's here in our clinic as well. For our wellness and care management programs in our nursing team, we have chronic care management, collaborative care management, which was new over the last year, and behavioral health care management, which also is new over the last year, that we've been trying to get billing and all those different components of those services worked out. We do annual wellness visits, and then of course, many other things as other primary clinics do that are working on quality improvement. We do have laboratory and imaging services on site. And then if you think of Palouse Medical as like 3 different services, we have internal medicine, family medicine, and then we have Ready Care. And Ready Care kind of helps fill those gaps for the things that we don't want patients to go to the ER for, but the times that they just still need to get in to see a primary care, or to get in to get that care that they need. So it's for those acute illnesses and minor injury needs. And we're open 6 days a week with that. So let's go to our next slide. All right. So on this one, we just want to really, again, thank Greater Columbia. We would not have been able to have the amount of success and the level of success that we've had without our partnership with you. This was something that we were in the process of doing pilots when we first met up with Carol Mosier, and she encouraged us to apply. And this made a huge difference on our patients and in our clinic. We were then able to get Leslie Robeson here and have her full time, and we have kept her busy. The last 2 years during the pandemic have just been a little insane for all of us, it looks like, from the presentations. And so one of the things that we're really proud of is that by having somebody on site, we're able to do that collaborative care, and it can be right with the provider and our behavioral health psychologist. And our providers will be the first ones to tell you that they don't know how Leslie does it. She has magic, whether it's a wand or whatever it is, but she just has a way of helping patients to navigate from what are health challenges and presenting barriers to their care, to being able to get them over those hurdles and saying, yes, I'll take my diabetic medication, and yes, I'll keep my appointments. And so I asked Dr. Fosbeck, that's a picture of her in the bottom corner. I'm pointing to my screen as if you can see. Dr. Fosbeck and Leslie, oh, thank you. I asked her for a quote of a recent positive experience, and she said, I can't tell you how grateful I am to have integrated behavioral health services available on site at our clinic. I can provide success stories for hours, but one beautiful experience that demonstrates the positive impact that this approach can have on a patient's life was just a few weeks ago. Leslie Robeson and I saw a patient together. Leslie was able to navigate some difficult challenges and successfully help a patient transition from oncology care to hospice care. We all 3 worked together to establish and see to the patient's end of life wishes. It was an unforgettable experience that reminds me how important the little things are and what being a healthcare team member is all about. And I think that really sums up why, you know, the days that are really, really hard for all of us, that it does make it worth it when we have the ability to use our resources within our clinic and then just see what an impact that can have. So to walk through the behavioral health integration workflow, so we've got Leslie on site, and so we've trained our staff, we've trained our front office staff, our phone operators, our nursing team, our providers, and everybody's looking for those signs and remaining aware. You know, they're aware of what social determinants are of health, and to look for those things where maybe a patient might be struggling but might be hesitant to mention that. And so they're looking for those anxiety and depression signs, or if there's any suicidal ideation and grief reaction. And then what they do is, once that's identified, the provider can talk to the patient about what their options are and introduce the idea of visiting with Leslie. And opportunities when that's available, that Leslie can pop into a room and we can do a warm handoff, that's our favorite, because she's able to do that collaborative care right there in the room with the provider. And Dr. Fosbeck and any of the providers will tell you that's the one, that's the money. That's the one where that one works the absolute best and where patients respond really, really well. She says she finds out things patients never would have said to her, and then they finally are able to get over those hurdles. But that's our behavioral health integration workflow. And if we can move to the next slide. We just wanted to make sure that we weren't focusing too much on some of the barriers that we faced, because these last few years have just been very draining. I feel like for anyone in healthcare, the pandemic has put a lot on everybody. But the biggest barrier for us has been staffing burnout and shortages. That being said, most of the people, I know you can't see everybody in the room here, but most of the people in the room, I'm the one that's been here the least amount of time, and I've been here 15 years. So I'll share these statistics with you, but understanding that some of these positions are the ones that have continual turnover with it. We have 13 providers, 10 PCPs, 2 Ready Care providers, and our health psychologist, Leslie. We typically average 55 to 60 employees and have a turnover rate of less than 6 employees a year. But since the start of the pandemic in March 2020, we've lost over 38 staff and providers to resignations. And the reasons, I know that this is not uncommon. You guys are probably all echoing the same thing or nodding right now while I'm saying this. It's whether the resignation is because of another job offer with a higher salary or a sign-on bonus that we can't afford as a private clinic to offer. We ran into issues with people who didn't believe in mask and vaccine mandates. And then those who just were done. They were all done once the pandemic hit. It was just too much with everything. And because we are on the border of Idaho, even just to give you an idea, it doesn't matter what we do to try to recruit for nursing. I feel so bad. Kim has been really struggling to try to get these positions on our nursing team replaced. And right now, I feel like I should stand on the sidewalk and twirl a sign and say, we are really fun to work for. But we're competing with people that are offering up to $4,000 sign-on bonuses for a CMA position just across the border. And so that does make it really difficult. The other big barrier that we've faced over the last couple of years, impacting our ability to put all of our attention to QI efforts and on closing care gaps and doing the things that we wanted to do, has been the increased workload. So you have the pandemic increasing their workload, and then we have the loss of the staff due to the pandemic increasing it. And so despite all of our recruitment efforts, we're still trying to replace those positions. And so that's created a lot of additional work we've had to absorb. And because we were actively involved in the pandemic and some of the testing and vaccination efforts, in addition to our daily care responsibilities, we've had staff working nights and weekends to assist with those COVID efforts within the community. One of the things that we found was, as we were starting to, nurses were retiring or people were accepting other job offers or moving, we've always had a one-to-one nursing provider relationship, something we've been proud of at Palouse Medical. And then that's been something that we've not been able to continue because we don't have a one-to-one nursing relationship right now as far as the amount of staff that we have. So if you go to the next slide. Oh, sorry. And we've also had increased costs, decrease in reimbursement. I'm sure no one else can understand those. And provider credentialing delays. So if we can go to the next one. These are some of the ways that we have worked to overcome these barriers. So for the staff shortages, we got our staff together. I'm so proud to be on a team like this, but Teresa and Kim, my camera is not capturing everybody. They were meeting together and saying, what are we going to do? We're not getting responses for the people that we're trying to recruit. And what can we do? And they said, you know, we need to engage everybody. We're a big clinic family, and this is all of our issue where we want to see what other ideas everybody else has, because maybe somebody has a better idea that we could try. So we took it to the staff. We invited everybody to come and to brainstorm with us. And so something that we've done this last year, so we did this in January, a clinic brainstorm, where we got the pulse of what they thought were the biggest issues that we needed to overcome in 2022. That was the first survey that we did, and we got staff feedback from that. From that, we got an idea of how we could potentially navigate our nursing shortages. And so we got the idea of what if we what if we implement a CNA and we're not getting CMAs, but what if we get a CNA to assist with our nursing teams and kind of help with those workflows? What if we restructure and we do some better efficiencies? And then another person or two had some ideas on a nursing pod structure, where instead of using 1-to-1 provider nurse ratio, you have a pod team, and then they're helping with different providers. And so we've been able to try several new ideas within our clinic, all because we have been engaging our staff. So that's been a way that we've been overcoming that issue. The second survey that we hope to get out here, and not even everybody in this room, I know, I don't think they all know about it, but we're going to do a staff survey that's an anonymous survey, where now we're asking everybody to kind of gauge how they're doing as an individual, kind of get the pulse of where they're at. Do they feel like they've got the tools that they need to be successful? And how is their day going? What keeps them here? Because we really do care about our employees, and it's been really hard to see so much turnover. And we're restructuring roles and streamlining our workflows. And when it comes to increased costs and decreased reimbursement, Teresa back here is going to be working on those value-based contracts. That's our big goal as we move forward. We're also hoping to become PCMH certified. And so we're hoping that by getting that certification, it'll validate the work that we are doing while keeping our high quality care standards up to the level that we want it to be. And then we're hoping that that'll help us as we're looking at financial sustainability for the future. One issue that I definitely want to share with you that has just been a nightmare of a struggle has been our delays in provider credentialing. We use 2 websites for provider credentialing, Provider Source or One Healthport and CAQH. And once those applications for providers are completed, insurances are supposed to be able to go in, pull that information out, and retrieve it as they need for that to process credentialing applications. And we had a brand new provider that joined our team last August, and we have been delayed on basically every level with this, and it's all been outside of our control. It's created duplicate work. We'll submit everything we need to into these 2 websites, but then the insurance companies aren't communicating back with us that they don't have what they need. And you'll get a canned email, and it's never really a person that you can talk to. And so we have been so frustrated with this. We're still fighting to get reimbursed for rendered services. It's decreased access to care and unnecessary patient delays that it just is so frustrating. I happened to glance over here on Teresa's email, and hopefully she doesn't mind me saying it, but here pops up another email, even just now, where it's another email where we're in this conversation still. So we're still fighting that one, but I believe we'll get through it. And then if you can go to the next slide. I'm not going to go through everything on this, but 2020, the pandemic, all of the COVID efforts that we had, we were staying pretty darn busy. We worked with the hospital to get a trailer so that when we were first doing our testing, that's a picture of our team out there working in the testing trailer, and they were doing drive-up testing. Then we worked in collaboration with the hospital, and we created the Ready Care Respiratory Center. And the whole goal was just to make sure we didn't have hospitals inundated with testing needs. We were able to open that October 2020. We closed it after the need decreased in March 2021. We've also been really proud that our Ready Care service has continued to provide that systematic testing and assessment, because that's kept sometimes upwards of 75 patients out of the ED every single day. So that's really important. Not that we're seeing 75 patients a day, but on our high days, we were seeing an incredibly high volume of patients needing that symptomatic testing. As of this week, we've helped collect and process over 11,000 COVID tests, and we became the first site back in December 2020 to receive the COVID vaccine here in the Palouse. And so then we ended up becoming the Whitman County distribution vaccine hub. And then until the other sites became able to be approved as sites, we were the one that was helping Whitman County get their vaccines as needed for clinics. We've held over 70 clinics. I had some other really fun pictures, even one where we went on site to some assisted care facilities and went directly to those patients and helped get their vaccines. But this is actually one of our admin team members. She ended up being our 5,000th dose, which was really exciting. So you have to celebrate the small things through all this hectic, I like all these hectic times. Can we go to the next slide, please? And then moments of success. Our annual wellness visits have been increasing each year. As you can see that, we seem to be on track for 2022, which we're excited about. Our COCM claims, which is that collaborative care management, that's a new billable service for us. And we really just started that, I believe, like July, right? Yeah, July of last year. So we had 98 successfully paid claims, and we're already at 30. And we're just in April of this year. So we think that we're heading in the right direction there. PHQ-9 screenings continue to increase each year. And we also just received notice that we are the top performing clinic within Washington State for the Kaiser Care Gaps that we're part of with a quality improvement program with them. And that's 5 years in a row. We're pretty proud of that one because it's up against Kaiser's clinics themselves. So we're beating their own people. So that's kind of fun. The other thing is that we have learned that not all programs are created equally. And we have been involved with some other quality improvement programs and just beat our head against the wall, wishing that they could be like Greater Columbia. We often would tell them that maybe they should contact Greater Columbia and find out some of the things they're doing because maybe they could improve their communication. But we can't emphasize enough how much we appreciate all the work that goes into that workbook. Sam, it pays off. You have been educating us well. We know what's expected and we're able to like meet those measures, but not everybody does that. Not everybody communicates clearly. So we just wanted to say we've appreciated everything working with Greater Columbia. We hope we can continue to partner with you guys on upcoming things. And I think I'm trying to stay within the time.
Thank you. No, that's a great report. And I certainly have some questions, but let's see if we have time for one or two from the group. And any one of those slides that you just saw, any one of those comments?
You can always reach out to us too after this. I'm bummed that we're not in person and can't see your faces.
Questions for Columbia Palouse Medical? I'm sorry. All right. Well,
there was one that popped up in the chat.
I see a question there from Lisa. How is COCM billable?
So actually, I was prepared for this. Go ahead and I think you can reach out to Martin. He can connect you to us for sure, so I can give you more information offline. But one of the things that we were using is this Washington State Healthcare Authority attestation for COCM services. And there's an attestation form that you can fill out, and that'll give you, this just covers Molina's coverage of it though, right?
Your Medicaid, yeah.
And Ashley would be more than happy to help answer some questions too on some of the ways that we were able to get those claims billable. But that was part of an AIMS program that we worked through it was a partnership between Premera and AIMS, where they were helping us to launch the collaborative care model within our clinic and also be able to recoup and make that a billable service. It is something that we struggle with even to this day. Yesterday, we were looking at the claims and I can see people do want this information. So I'm going to put our email in the chat. And then if you want information about this, we can reach out afterwards and we'll get you that. So.
All right. Thank you. Thank you so
welcome.
much, Palouse Medical. That was a great presentation. Let's move now a little further west and south to Walla Walla and hear from Providence St. Mary from Becky Betts in particular. Becky, the floor is yours.
Becky, I have that PowerPoint that you sent me. If you want me to share my screen, I can, or if you would like to, you're welcome to as well, whichever you prefer.
That would be great if you have it up. Thank you. That'd be awesome. Thank you, Dr. Jones. All right. I am thrilled to be with you today and kind of wrap things up. I'm excited that Martine reached out and let me talk about my favorite part of the MTP. And I want to talk to you about my favorite is the most beautiful milestone for C1, which has to do with our collaboratives, our compact collaboratives and our partnerships. Next slide. I think this is a very powerful visual, literally a guy pushing up a stone up a mile, get it, milestone, really play on words. Seriously, these past few years have drained us all, drained all of humanity really. Anyone left out there that think they can do it alone, good luck. This work is too hard. We have to pool our resources, our imagination, and our ideas to get anywhere. Next slide. This is just my quick list that I came up with, the benefits of community partnerships as I see it, that obviously our resources go farther and we are able to tap unique skill sets, which we all bring, and increase community awareness around an issue, provide framework and stabilization for sustainability, the power of accountability, which is very important, and the opportunity to see and understand issues from different perspectives. Next slide. But, you know, I think that Robert Wood Johnson's foundation says it way more eloquently. Here is what they say about partnerships. We think a paradigm shift is occurring in America. There is a growing realization that controlling the increase in health expenditures and improving the health of our nation's population will require major changes in traditional policies, practices, and organizational models. These partnerships are bold pioneers, and we hope as harbingers of a new era of innovation and multi-sector collaboration focused on building a robust culture of health throughout America. Next slide. I really like the work of Arthur Himmelman, and he is a nationally recognized scholar on community and system change collaboration. And he describes here in his theory that partnerships are really built on a continuum, which always starts with networking, which we're all familiar with. We do all the time. Anytime we can get in a room together, look around, we're networking, which is an exchange of information for mutual benefit. And then the next step is that layering, the coordinating, we're exchanging information, but we're also altering activities for the mutual benefit to achieve a common purpose. And the next layer is cooperating. So we do the activities of the former plus share resources. And finally, the kingpin is collaborating. We're exchanging information, altering activities, sharing the resources, but finally enhancing the capacity for another for mutual benefit to again achieve the common purpose. Nope, next slide, you're good. So I want to talk to you a little bit about our compact collaborative partnerships that we have entered under our MTP, under our milestones, under our Greater Columbia ACH work. Next slide. Probably the biggest and the boldest is our mobile RV project. MOST stands for Mobile Outreach Service Team. And this is a endeavor that is a triad. 3 agencies came together to form a compact. Any of the 3 agencies probably could not have done this alone, but you know, the power of us together really are making it happen. We worked with a mediator and developed a strategic plan, a 5-year strategic plan, a mission, and a value statement. And it really is a mobile multi-agency outreach program, which is dispatched to communities in areas where poor, vulnerable, and homeless people live and congregate. And the 3 organizations that comprise the core services are the Walla Walla Alliance for the Homeless, Blue Mountain Action Council, and Providence Population Health. And each is providing a unique and non-redundant service to the population. So the Walla Walla Alliance for the Homeless provides the vehicle itself, maintains the RV, provides the driver and peer support specialists. Blue Mountain Action Council provides those housing navigators and the coordinated entry, and they can mobilize a full array of services offered by BMAC. And then we provide a nurse practitioner, bilingual, as well as a promotora, a Spanish-speaking community health worker, and other health specialists as need. Next slide. You can see this is some of our team members. multi-agency workers. These are Providence Population Health, as well as peer navigators from the Alliance and the Sleep Center, which is our homeless campment in front of the mobile RV. One big happy family. Next slide. We are thrilled that we brought a bilingual nurse practitioner on board. This is Abby, giddy over her equipment like a kid in a candy store. Next slide. Another a milestone partnership compact was one with Blue Mountain Health Cooperative, which is just such a wonderful organization. And they successfully launched a workforce development site. And they are our neighbors on our Providence Population Health building. On the Southgate campus, they opened in February 2021. And this is a workforce development site for Walla Walla University social work students and Walla Walla Community College Health and Human Services students, where they can get practicum support and the experience they need in time of COVID. Practicum sites decreased up to 40% for students. And so not only are we a health professional designated shortage area for behavioral health, but we're not going to be able to hire ourselves out of this if we don't develop and grow the next generation of providers. So this was kind of the two for one, right? We are bridging a gap in our community where wait lists for private counselors are long as your arm and then some, 6-month waiting list. So it could provide, the patients could walk in free, no questions asked. They could get the counseling from students in a supervised forum, and then they could get the behavioral health navigation help into the provider. So when they did land in the community providers, they were teed up and made sure that their insurance was accepted, that the provider was a good match for them. So they've wildly outgrown the building and expanding into the Tri-Cities. This model has been wildly successful, and we're very proud that we were part of that initial partnership. Next slide. This is just their lobby. It's beautiful and serene. Sometimes people just go sit in the lobby and feel better. Next slide. And that's one of the therapy rooms. The other partnership, many of you have heard, I'm not going to spend a lot of time on, but of course, Cody Main, our partnership with the city of Walla Walla, we formalized our community paramedic program, which is just about to celebrate its first anniversary. It's been wildly successful. Tremendously supportive of this model, thanks to the Greater Columbia ACH. And it's a low-hanging fruit for many communities. Really go out and explore what a community paramedic can do for you. We are, every day, our eyes get bigger on the value and the yield that Cody brings to the streets. City of Walla Walla just hired a second one that started on Monday. So hoping to just grow the program. Next slide. COVID and the community drove the need for rapid, nimble partnerships. And one of them that we all experienced front and center was the health inequities that disseminated our Latinx populations in our region. And that's where we found alignment with Vital Wines. Vital Wines is a nonprofit winery in Walla Walla, and their mission is really to support and inclusion of the vineyard and winery workers in our local communities who got particularly hit hard during COVID. And speaking, that really spoke to our mission and vision of wanting to minister to the poor and vulnerable. So it was a match made in heaven. Next slide. They help fund Maria, who many of you met and heard speak last month. She is a promotora, community health worker, whose really her purpose is to go out into those fields and vineyards and meet people where they're at, migrant neighborhoods, and begin to build back those bridges of trust, which may have been lost with systems and hospitals and government agencies. Next slide. She is a powerhouse, and she is a one-woman show. She's hosting a resource fair. I invite you all to it this Saturday at Valley Lindo in Walla Walla. We do love a good party here in Walla Walla. She hosted a resource fair in February that had 7 community service organizations. This one has grown to 15. Sponsored by Providence, Vital, and our amazing partners at our Department of Community Health, which will be there providing vaccinations. This just speaks to the power of community. Even Maria's nuances of making sure that everything we put out has Spanish translation has been a huge win, something we were not good at. And she just makes sure that everything goes out in Spanish as well. Next slide. This is a picture that we've used before, just of Maria really out in the fields, meeting people where they're at, delivering heart health information. Another partnership that just has symbiosis written all over it is one that we've entered with our Children's Home Society of Washington, such a wonderful organization. They have a site here in Walla Walla that runs our early Head Start program, and amazing, you know, many things, birth to 3, all sorts of things they do at their campus. But, you know, from a health system and primary clinics, we really watch Amanda, who's on the call, as our manager of population health, and looks at our value-based care lives and sees disturbing trends when we start to see our Medicaid lives fall behind on annual wellness visits, and particularly our littles. And once they start to tick down on childhood immunizations, this was really delayed and more significant during the past 2 years of the pandemic. So it makes sense to partner with somebody like Children's Home Society. They needed a nurse to service their early Head Start families and do home visits and educate families on the importance of childhood wellness visits and vaccines and dental visits and developmental milestones. And that aligned with our needs as well. So rather than duplicate, let's join forces. The other creative idea we had is, let's go ahead and use this nurse to round in women's services, our OB unit, and visit new Medicaid moms and do the assessment there and intake. That is the natural feeder to Children's Home Society and early Head Start. And boy, you know, from a population health perspective, the more upstream we can get, our aim. And when you have a mom and a newborn, that's really upstream. So we're really proud of this partnership. Next slide. And wrapping up, I really want to end this morning with a story of Lewis. Martine asked to share a success story, and this one goes out to Martine. And Sam, I hope you're still on the call, because I'm hoping that you'll cry. This story is—
You know I will.
I hope so. This story is recent and fresh and really beautifully demonstrates the power of community and the need for partnerships, especially when the rocks are so heavy and agencies are acting insular. You feel stuck. So you can just keep it on that slide. And I'm going to read the story of Lewis. Lewis came on our population health radar a few months ago, but Lewis is 78 and he was born in Cuba. He is the baby of 22 from his father's first marriage. At the age of 9, he started playing baseball. This passion would lead him to play in the professional league in Cuba till 1971. He started playing guitar as a teen with his friends. He comes from a long line of musicians. His mother sang and his siblings also play guitar. He also experienced domestic violence in his home. His father beat his mother. He started drinking alcohol at age 8. At age 22, he got married and had a son. At age 28, he suffered an accident that would change everything. He was hit by a bus and spent 6 months in the hospital. The accident resulted in fractures and a head injury. He decided to come to the United States under President Jimmy Carter, since a group of refugees arrived by boat from the port of Mariel. They were called the Marielitos. I butchered that, sorry. He landed in Corpus Christi, Texas in '81, and then on to California. It was then a friend invited him to come to Wapato, Washington to work in the fields, but he heard Walla Walla was more lovely and decided to move here. In 2008, he lost his roommate, and that was just such a hard blow. He has dealt with these losses and the blows and the frustration of his life by drinking. He is lonely, and he misses his family in Cuba and feels lots of guilt around leaving them. His alcoholism causes erratic behavior, and his friends and acquaintances withdrawal. He has Medicaid. He receives Social Security and food stamps. He lived at our homeless shelter for a year till Blue Mountain Action Council finally helped him find an apartment. Hope Heals, an agency here in town, helped him furnish his apartment, and Providence Population Health with Promotora Maria assists with resources and language translation. Alcohol has taken a toll. When he feels sick, he calls 911 and he requests transport to the emergency department. He is what we call a super high utilizer of 911, EMS, and the ED. One weekend in February, he called 911 over 20 times. He is close to losing his housing voucher and being evicted from his apartment due to his escalating behaviors. We all fell stuck between a rock and a hard place, just like this graphic on your screen. In March, we held a community case conference hosted by Population Health with organizations involved in Lewis's care. The meeting was a little different than most. We shared ideas that might help mitigate Lewis's loneliness, which is a primary driver of his drinking. If we could find a solution to curb his alcohol use, might his overuse of 911, EMS, and the ED subside? Organizations pooled resources and got him some cable and internet, opening a whole new world. He watches his beloved baseball and FaceTimes with his family in Cuba. When Lewis is not under the influence of alcohol, he is a kind man. He enjoys playing guitar, writing poems. With the help of his community, he is making every effort to get better. He likes that his Providence community health worker, Brian, visits him. Promotora Maria calls him every day to see how he's doing. Cody, the community paramedic, checks on his blood pressure weekly. Since the community case conference and the creative interventions were implemented, Lewis's EMS and ED utilization has ceased. At a recent Latinx community event on cancer prevention, Lewis was the door greeter. Maria made him door greeter. Next slide. He played guitar for community organizations, and he's sharing his musical gift with others. Lewis's path to well-being from creative collaborations from these community partners in Walla Walla and his desire to live a better life is really making all the difference for this gentleman. And I have full permission to share. He's been very generous with his story and this desire to share his story with our community, and we are tremendously grateful for that. Next slide. And it's too much for one person, too much for one agency. These are all the people that are wrapped themselves around and Lewis, and it's heavy lifting and it's a lot and it's resource intense, but you know, baby steps, we'll get there. We'll get him more independent and on his road to recovery, and but no utilization after over 100. And that is on our dime. That is a Medicaid plan that is cost savings. Next slide. These are just a menagerie of the partnerships we have through the eyes of Medicaid transformation. And we look everywhere, we say yes to everything. And I'm just so grateful that we, you know, got our sea legs through the eyes of Medicaid transformation, really pushed from GCASH to explore what partnerships could look like. Our Department of Community Health, our own health department, we share a cell phone. Population Health and the health department share a cell phone, and we're that integrated and partnered. We hand a cell phone back and forth. We share it week by week. So next slide. My idol, American cultural anthropologist Margaret Mead, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has. Next slide. Barriers, just really quickly, of course, you know, when you're merging organizations, it's the legalese that gets in the way, the MOUs, the PAAs, the data sharing, the compliance, all those necessary evils, but don't let that deter you. Push through it. We just got to do it. You got to do it for the good. You got to do it for the North Star. And the HCA and the MCOs, what I'd like to say to them, what I always say to them is that we need to reimburse directly for community based workforce services, and we need Medicaid dollars leveraged to fund your agencies that address social determinants of health. Otherwise, that rock is too heavy when it lands in the emergency department or hospital. So if we can fund your agencies that address social determinants, we'd be better off. So I really thank you for your time, your attention, and your invitation. So thank you.
Wonderful presentation, Becky. And I just hate to say it, but we don't have time for a lot of comments right now because we're just at the end of our hour or 2 hours. And so I think people know how to find you, Rebecca.Betts, correct?
That's correct. Thank you.
Providence.com. So
thank you.
Thank you again for another good presentation. So let's finish with Quality Behavioral Health. This organization has already been referenced in our conversations today. And Whitney, are you ready to take it away?
I am, yes, thank you.
Okay, we got about 10 minutes.
I will make it as brief as I can, thanks.
I don't have a presentation of yours to share. I don't know if you have one ready.
I do have a visual here, I will share my screen and pull that up.
Okay.
Okay. So thank you for the time this morning. First of all, I'm Whitney Bone. I'm the practice transformation specialist and mental health case manager here at Quality Behavioral Health in Clarkston. I have been here a little over 5 years, so I've been here since the beginning of this practice transformation program. You know, we've really seen this program as overall a growing success over the last few years. The beginning, of course, kind of had its kinks and stumbles along the way, getting things aligned and getting up and going and organized. But it's really progressed into a really beneficial and fabulous way of monitoring and assisting our clients in their mental health and substance use disorder treatment and those treatment plans. The visual that I have up is our risk stratification, which you're all familiar with. I kind of wanted to focus on this mostly as one of our biggest successes, and to really highlight how that has been a success in terms of the client's treatment. We use the following quality metrics you see at the top of the screen there. You know, we use their primary diagnosis is on the far left column, but then those quality metrics, their number of meds they're currently taking, the number of inpatient hospitalizations they've had, the DOS-21 that they've completed, the MDQ, a trauma checklist, and then our clinicians fill out a clinical judgment of risk checklist. So the clients complete all of the screens except for that last one, the clinician judgment of risk. And that's simply a yes or no short version checklist that their clinician, either their SED counselor or their mental health therapist, they complete that. And, you know, just it's kind of obvious there. It's just their clinical judgment of where they see the client. All of our clients coming through the door here at QBH, they complete these screens at time of intake. So to ensure that nobody's missed, we use the risk stratification then and of course, like you're all familiar with, we identify the top 10% of highest risk clientele using the screens, and then I provide the case management services. We have found, like I said, this one of our program's biggest successes. You know, we're able to see, utilizing the screen, total scores there in column M, where a client is at in terms of their behavioral health, and then upon rescreening them every 3 months, we try to get that done on a quarterly basis, we see how they've then progressed or declined. You know, we had, for example, we had a client who came in, they were unhoused, unemployed, and missing several other of those major life domains, and through case management services and our wraparound services, with our PT dollars, we were able to expand and hire a telehealth provider. So also with him on the team and his input, we saw that client just starting to knock off those goals, you know, and with the proper help and wraparound services, able to complete those goals. And within 4 or 5 months, we saw her total score drastically decrease, scoring much lower on almost all of those screens. And the clinical judgment checklist went, I think, from about 8 to 1. You know, we've also been able to, with risk stratification and the rescreening and monitoring, we've seen situations where the scores improve, and notice the only change may be the number of meds they're taking. You know, sometimes the addition of meds is indicative of lower anxiety or depression or other health problems. Whereas sometimes we see a decrease in meds, and that could possibly show a med adjustment that's accounted for the change there in the screen scores. And again, all of these things we take back to our wraparound practice transformation team, who meets on a weekly basis. That team includes, we have a couple doctors on staff, an RN, a MA, myself, case manager, and the practice transformation specialist. Oftentimes they're counselors, be it a sub-counselor or a mental health counselor or both. And then they're external players, you know, they're PCP. We've had a dentist come into a few meetings. So all of that collaboration has been significantly helpful for not only us in being able to provide the appropriate pathways for the client's treatment, but beneficial for the clients, of course, and having their voice involved and having them kind of see the wraparound services at work, so to speak. The team collaboration, like I said, it's been really beneficial in evaluating the client scores and changes over the months. And, you know, we've also seen things like if a client whose scores have significantly changed, now whether that be an increase or decrease, we have their therapist sitting there in the room during these meetings in our collaboration times, you know, to give their input, their clinical judgment, and say perhaps why they think that may be, you know, what in clinical terms, what they're seeing happening with that client. We've also seen client screens change, and clinicians have pointed out that the client came in that day and completed those screens when they were completely escalated. Or on the contrary, the client was observed as being manic that day. And so, you know, perhaps the screen scores are reflecting that. All in all, those metrics and the screens and the scoring, it's provided our team an awesome way to monitor and better look into the scope of treatment for clients, and meeting them where they are with the complete practice transformation wraparound services. Some barriers that we've had, of course, I think most people hit upon this, but when COVID came up, when COVID hit a few years ago, this presented a huge barrier, in our implementation for rather obvious reasons, I think. And, you know, we shut our doors, so no in-person services were provided anymore there for a time. We weren't able to screen clients the same way, if at all. We also, another barrier then that occurred was difficulty in staffing, you know, that gap in staffing and filling those positions and the recruitment and hiring. These things have mostly resolved at this point, although the latter, the filling of staff positions, that's something that's kind of ongoing that we're working through, which I think is kind of a recurring theme for many agencies here, especially in the LC Valley. And then another barrier, you know, when we're dealing with behavioral health clinics and the such, we get the loss of contacts, the no-shows, you know, can't force anyone to do anything, of course, so no longer amenable to services. And these obviously disconnect us from being able to monitor and, again, provide those appropriate pathways to treatment, both clinically and in terms of case management. You know, in looking to the future and the next year and beyond, we'd really like to and plan on continuing our efforts in practice transformation work and really growing the program, specifically our children's services. With cohort dollars in the past, we were able to expand our clinic here and open a new building, a new service department that specifically treats children. So we have all our children therapists over there, and as well as our WISE team. They're a wraparound intensive service team. They're housed there. And we'd like to get some more case managers who are, you know, specialized to work with children. We'd like to get that up and going. We also want to kind of explore continued funding efforts, of course, to support these things, and as well as through the HCA. We'll also be relooking at how, with the end of practice transformation, how we as an agency open the doors to more than just our mental health and SUD programs for providing this practice transformation work. And maybe then, with less adherence to workbook guidelines. But overall, in terms of what the HCA can do to help our organization with continuing practice transformation, just generally helping out with resources so we can continue the effort, as I've hit upon. Wouldn't it be great to have those matching previously received dollars per each cohort, and as well as increasing the dollars perhaps for those who are continuing to build the programs, possibly rewarding longevity with dollars to match, just exploring different avenues like those, just things of that nature. Bottom line being, helping out with some options for resources so we can make it all possible and continue the effort to help out our clientele here. I know that was pretty brief, but I'm looking at the time. Do I have any questions?
Yeah, Whitney, thank you so much. I know this is for all of you on the line still with us. This was sort of a last minute presence of quality behavioral health. So we want to thank you, Whitney, for putting something together quickly.
Yeah, no, thank you. Like I said, I appreciate the time this morning.
Great. All right. Well, we are 5 minutes away from, or now 4 minutes away from 11:30. Before we go, we have a bit of an announcement on our side. And I don't know whether Sharon or Sam. Okay, so we don't need all three of you to do this, guys. So why don't you pick one, and we will get the word out about the public comment period. Who wants to hold forth?
We'll let Sharon do it.
Yep, that's what I was going to say.
You're gonna let Sharon do it.
We really appreciate everything, all the comments that have been made about GCACH here today. And we're really going to need your support now. The Healthcare Authority is going to be pushing out a public comment period in the next couple of weeks, and we'll send out a notice to let you know exactly when that is. But we really need all of our partners and partner organizations to reach out to the Healthcare Authority with all of the comments that you have made here today that have been so impactful to us as a team, but also the people that we help, the lives that we touch in the communities, and to write to the Healthcare Authority and let them know that we really are making a difference with these dollars, and they are flowing directly into the community and changing people's lives. Thanks.
All right, so that will be coming up sometime soon, Sharon or team. When will that comment period?
Yes, the Healthcare Authority just pushed it out another couple of weeks, and so we will let you know the exact dates.
Okay,
as
so
soon as it's released.
Everyone on the call will hear from staff, right?
Yes.
Just about what is up.
Yes.
All right, well, we certainly experienced, I think, a wonderful sampling of all the good work that's going on in the 9 counties from, well, we didn't hear from Kittitas today, but certainly from the 9 counties from Kittitas over to Asotin. And we hope you enjoyed your time. Thanks to all of you for staying the course. And
don't forget to take the survey.
Yeah, we will definitely want to ask for some feedback. We always do. That helps guide the choices of content in these meetings. So please take a little bit of time before you log off to just fill in those 2 or 3 questions. And I think with that, we are done. Sam, do you want to just give voice to what you just wrote? Or not?
Yes, can you hear me?
Yes.
Yes, I just wanted to say that out of all 3 cohorts and the 82 organizations, we're just so proud of them and all the work, especially through such difficult period of time of COVID, and just congratulate them and just the way that they've been innovative to truly implement practice transformation into their culture. The stories, they're just so heartfelt and truly innovative to better patient outcomes. And we would have loved to hear from everyone today, and hopefully in the future we'll be reaching out and we'll be able to get more of you to be able to report out, because across the board, these stories are heard from every organization. Thank you.
All right, Sam, thank you so much. And we wish everyone a green and blue next couple days with Earth Day celebrations. And may we see you again in the month of May 19th at 8:30. So we are adjourned.